Hello, and welcome to today's HealthITSecurity.com presentation from Imprivata, Authentication Simplified, Fast, Secure Access to PHI, and Seamless EPCS at Peninsula Regional Medical Center. I am Elizabeth Snell, editor at Xtelligent Media and moderator of today's presentation. Before beginning, I would like to take a moment to thank our sponsor. Imprivata, the healthcare IT security company, provides healthcare organizations globally with a platform that delivers authentication management, fast access to patient information, secure communications, and positive patient identification. Imprivata enables care providers to securely and efficiently access, communicate, and transact patient health information to address critical compliance and security challenges while improving productivity and the patient experience. We will begin with a presentation by our speakers and conclude with a question and answer segment. Audience members can submit questions at any time during the webcast using the question tool to the left of the screen. For all technical matters or difficulties, click the Help icon at the top right-hand corner of the screen. A copy of the presentation slides and a recording of the webcast will be made available following this presentation. Now on to our speakers. Dr. Christopher Snyder has been in primary care and hospital medicine for 21 years. He is currently the Chief Medical Information Officer, Chief Quality Officer, and the Physician Advisor for Utilization Review and Case Management at PRMC. Dr. Snyder became the Chief Medical Information Officer in 2004 and has been involved in the development and implementation of multiple integrated clinical informatics systems. Dan Borgasano is the Senior Product Marketing Manager for Imprivata Confirm ID. He has more than 10 years of experience in healthcare IT security, including expertise in the DEA requirements and best practices for electronic prescribing of controlled substances. Dan is a graduate of Syracuse University in Syracuse, New York. With that, I would like to hand the floor to Dr. Snyder to begin today's presentation.
Well, thank you very much. So good morning or good afternoon, depending on where you're at, but kind of excited to show this again. We've shared this a few times, and hopefully we can give you guys some ideas on how to utilize the Imprivata tools and how we've been successful with operationalizing these things with our new Epic version that we picked up last year. First thing I want to do is kind of go through what Peninsula Regional is all about. We're located in Salisbury, Maryland, which is about 30 miles from the ocean, the Atlantic Ocean, and about 120 miles east of Annapolis, Maryland. So we're in a fairly rural area. We have probably the largest business in the community, and we serve Delaware, Virginia, and Maryland. We have probably about 3,500 employees. As you can see, we have anywhere from 400 to 450 community-based physicians, fairly older population physicians too. We have really no teaching staff, and we have an extremely busy ER, unfortunately at 95,000 ED visits a year. So probably the third or fourth busiest emergency department in the state of Maryland. We care for about 288 beds acutely, and those beds live around 80 to 85% occupancy around 365 days a year. We do regional trauma, and we do pretty much everything but transplant. We have a integrated outpatient cancer center also. We had the fortunate adventure of going live with Big Bang with 19 offices and our entire inpatient ED and multiple medical record systems were migrated to Epic November 1st, 2016, and saying we're doing very well 8 months out, and we've actually had go live was as fun as ever. I'm sure I get a few smiles out there, but once we got through the first 3 months, we had significant positives that have occurred, and we're doing well at version 2015 and migrating to 17 next April. So that's where we live in our EMR world, and a little bit more about what Imprivata was. So the snapshot of Imprivata, basically, we were using Imprivata prior with OneSign. As you can see our numbers there, we have a fair amount of licenses, and I'd say we're more than 80% deployed since the slide went up, because we've really added a number of devices in our operating room because of requests. from the bedside caregivers, from the front office workers, et cetera. We have a significant amount of logins, as you can see, about 130,000 workstations per week, about 300,000 application events per year, 200 users doing electronic prescribing, which we're getting ready to roll out a bunch more as we've adopted Epic and everybody settled down with the day-to-day workflows. It's now a time where folks are asking, how do we get some of these bells and whistles up and running? And the Imprivata tool has clearly made that a pretty simple migration towards getting folks to use electronic prescribing of controlled substances. Primary authentication methods, we have single sign-on with proximity badge. We tap and go all our doors and our entryways now. Also, that's just happened in the last couple months. And we're also utilizing EPCS with password and push token, which has become a very, very popular tool for providers as they learn to e-prescribe controlled substances. And there's a lot of regulatory things obviously changing in our environment on a day-to-day basis. So before Imprivata and single sign-on, we had a deluge of multiple EMRs and applications. We used multiple products prior to Epic. In fact, we had 12 applications that were in the inpatient side with different users' names or passwords, and many of you share that frustration, I'm sure. In a 12-hour shift, our RNs shared that they would log in 100+ times each application. So just add that up, and kind of hard to pass meds at that time. We also had challenges with limited technology adoption, and then generic logins were limited into who was accessing the information. So there were some security risks and significant provider frustration with access, and which is again a huge benefit of rolling out these tools. So the solution, we developed one of the key elements that Epic forced us to move to was getting our Active Directory up to speed, and those accounts for all users were extremely important. So we were leveraging that single source of information about providers and staff, and then also virtualization of our network, getting our desktop optimization up using zero clients, and getting that speed to where we need it to be was a little bit challenging after go live, but once go live occurred and we were able to settle into the standard functionality that was built out on the servers, I think that leverage and that capability really allowed us to give certain pools of information to the providers that needed it, and that tap in, tap out session was fantastic, and actually just far exceeded our speed of any sort of password authentication. Let alone even our prior to go live with Epic. I think our zero client access was limited by, again, multiple passwords and very slow access. Now that we're up with Epic, and that integration with Epic really has become super quick to go from device to device. And as you can see, I mean, the folks here are begging us to put these zero clients out there because they realize how quickly they can get to the information, and some of the interesting things within Epic allow you to do those secure access points and get shared desktops at the bedside, in our offices, in our emergency department, and in certain areas, procedural areas, and like the operating room. So there's some wonderful tools. My cardiothoracic surgeons were begging for us to give these access points in there. In fact, prior to this, they really didn't wear their badges in the OR, although badges can be somewhat dirty, but they carry them in their wallet in their pocket now, so they can tap in and tap out post-operatively, because it just gives them that quick access to the clinical needs. So some of the challenges of e-prescribing controlled substances are obviously no-brainers. Why our federal government's moving towards us doing PDMP. State of Maryland's, we have an HIE, so we are in a PDMP early process, and we're working towards mandating that throughout the state, which I think will be well received because of some of the things we've done, at least in our community. And obviously we have the opiate epidemic. We really need to make sure we have good awareness of what we're doing. So the paper prescriptions were kind of a no-brainer to get rid of those for obvious reasons. The pharmacies are pushing for e-prescribing just so we can get a consistent authentication and obviously reduce reducing fraud and inappropriate scripts. And then a migration to Epic presented opportunity to give us EPCS. So we didn't go big bang with EPCS at first because it was fairly new and we had a few other projects going on during that time frame. But that being said, it has never lost sight of being one of those things that we weekly discuss with certain groups. Again, utilizing this early on with your high prescribers, oncology, palliative care, comfort care folks, and then also in the pain management world, in the ambulatory setting, we're all very, very, very powerful places to start and to really test a high volume practice with using EPCS. So the regulatory considerations, obviously we had to do identity proofing and credentialing. We have a very strong medical staff office here. I report as a CMIO. I'm a hospitalist, but I also report to the CMO, and his staff is at my beck and call for this. They are folks who do all our credentialing and do a fantastic job of that, but they also have ownership of assisting in the enabling of permissions within Imprivata. They really have adopted to that and have been very helpful and instrumental, not only with go live adoption, but now also with new providers as we bring them through. And we're changing the way and the structure about how we do that and make sure folks have access to these tools. And then the auditing and reporting is something we're looking at on a monthly basis to monitor who's utilizing EPCS and who's not. And then some of the e-prescribing capabilities, not only with Imprivata, but even with Epic, obviously, we're able to manage those things and monitor. So our EPCS team was initially driven by IT because this was obviously relative to Imprivata's installation and utilization with devices. So the IT clinical collaboration was led by myself and the CIO, and the staff associated with that were application analysts, obviously from Epic, since it needs to be handled, and our ambulatory team owns EPCS from the Epic side. And then the systems engineers and obviously server engineers were imperative. Our server engineers, especially a guy named Ryan Ogburn, was just phenomenal, and him and Eric Harrison are two folks who help manage us, and Allison would be the third person who's been added on since then, are extremely powerful because what they did was they took our early speed in Epic and turned it up by 10 and gave us that real speed by building the server out so that it would be optimized for access to clinical information using the application Imprivata. So why do you want to use Confirm ID? It's a single platform. It leverages the same infrastructure. Like I said, we even get in our doors now with it. So it really makes you use that badge in all facets of care to get into patient rooms, into patient access for IT, and now e-prescribing on top of that for our controlled substances. So comprehensive functionality meets the DEA requirements. And again, docs get a little squirmish when you're fingerprinting them to get their biometrics in there, but they also do understand the impact that it has in their workflow and are very comfortable with that. And the speed of the enrollment is very simple. The best solutions, the one we use most, is the push token, which we'll show you a picture of here in a second. But the push token is seamless with Epic. When you do your discharge medrec, you go through your reconciliation and you pick which drugs you want to prescribe. At the end of that ordering process, it clearly demarcates what you want to prescribe, where you want to prescribe it to, and then the two-factor authentication is very simple with that. So this is an easy project to grow because it is so simple within the Epic workflow. It was kind of a no-brainer, and folks were literally asking for it once they got comfortable with the process. Identity proofing, again, institutional identity proofing was conducted through our credentialing office. So we had 5 folks down there, including myself. We're actually rolling that now since we've passed adoption and we're in optimization out to the trainers under the Epic world. So we are going to be enrolling them into so they can be help us with when we train new providers coming on here to ensure they have the ability to EPCS. The assigned administrators, they facilitate this, they help manage this, and they give IT the authority to give EPCS, so they own that, and that's where it should be owned, is in your credentialing office. They have the information needed for that. And then the individuals must also be separate from those conducting the identity proofing. So you really need these very specific people. Having non-clinical people do this is absolutely wonderful. They're very focused on this, and they do an excellent job for us up in our med staff office. So two-factor authentication, again, you need two of the following. You need either something you have, something you know, or something you are. We kind of use a mix of this. We pretty much use our token, and then we also use our passwords too, depending on which environment you're in. But both are very simple and very easy to manage. The fingerprint biometrics we have trialed in our high volume areas, like in the rooms with our pain specialists. And they have found those to be a very positive event, and we'll be doing some proximity assessment for that also, where we can actually utilize the proximity tools, so you don't even have to pull your phone out of your pocket to accept. So those things will be very positive. Let's see. And then finally, kind of a picture of how quickly this occurs. This is probably one of those things that really I don't think you understand until you actually prescribe. But basically, what happens is once you're password in or tokened in or biometric in with your finger, it pings your phone, and again, this ping of your phone, it delivers just basically a message on your smartphone, and you basically click on it, and you're done. So it's so quick, and it has such little interruption in the workflow. It's very easily adopted. In fact, when I train providers to do this and show them this, they are just truly shocked, like, oh, that was it, is the comment I get. And that's really one of those key things why it's easy to sell this product to them for EPCS. And then, oh, by the way, remember their badge is on their chest for authenticating to get into Epic. So they just find it very simple, and it's just one of those win-wins. It's very easy to sell to them. Results, again, they get better efficiency, they get better satisfaction. Obviously, the patients love this. Again, the pharmacies are much happier. It's safer, it's more efficient. It defines what we should be doing with controlled substances, and it allows us to track this also. And again, low resistance to use is huge. When you're rolling out EMR as much as we've done for years here, and those of you on the phone, you know what that feels like. It's hard enough to roll this out without throwing in a whole bunch of other wrenches into the workflows. This clearly was one of those things that was simple to sell. So your tips for success: communicate, open sign up, get folks enrolled early. During the initial process of training physicians for Epic, while we had the physicians in the room, our specialty trainers actually trained them in EPCS, so they had an awareness prior to go live. Now we do it as part of our standard orientation and the 4-hour time I get with providers to train them in Epic. EPCS is clearly one of those things that we give them as a tool that they can utilize and train them on it, enroll them, etc. Tip sheets for EPCS, push notifications. It's real easy to get those and take pictures of what I've shown you already, but there's nothing like actually performing the task. So getting that e-prescription and pinging that to your phone is always a very aha moment for doctors. And then finally, the last couple things: non-clinical staff to enroll via MedStaff. You don't need clinicians. We don't need specially trained folks here. They just have to understand the workflow. It's a very quick 30-second process, literally. As long as they have their badge enrolled, that's probably one of the main things in our world, is to get their badge enrolled. But once you tap them in with their badge, it's so simple to go into the Imprivata toolkit, enroll them with a separate person, place in your authentication, and then you're done and ready to prescribe. And then finally, engage the pain specialist. Pain specialists, oncology, we all know who those folks are. You'll find there's a number of doctors who don't want to e-prescribe narcotics because they don't. So your hospitalist is a big group to grab because they end up taking care of a lot of sicklers, and at least in our environment, a number of different other specialties are out there. Surgeons use these post-op, and they'll use them for ambulatory orders when they discharge a patient from the OR in the step-down unit. So there's some wonderful areas where you can really engage providers to use this tool, and like I said, it's a pretty simple win. So I think I'm going to hand off to Dan at this point.
Great. Thank you very much, Dr. Snyder, and hello, everyone. So before we open it up to questions, I will walk through a little more details about the solution that Dr. Snyder and his colleagues at Peninsula Regional Medical Center are using, in this case specifically for EPCS is what I'll focus on, and our product is called Imprivata Confirm ID. So before I talk about some of the product specifics, I just wanted to point out that there's been a lot of movement on the regulatory front related to EPCS. Many of you may be aware that New York was the first state to mandate electronic prescribing of all medications, including controlled substances, through a law known as PHI. That took effect in March of last year. Since then, the states of Maine, Virginia, and just last week, Connecticut have passed EPCS mandates. Maine will take effect in July of this year. Virginia is 2020, and Connecticut is January of 2018. But there are a number of other additional states that have legislation kind of pending in the different state assemblies and at varying different statuses. So, while there is, a number of compelling reasons to do EPCS from a physician and patient satisfaction and patient safety perspective, there's a lot of regulatory movement here, and it may be worth staying ahead of this curve. So now with that, talk about Imprivata Confirm ID, and it's really designed to be the fast, secure signing solution for EPCS, and we really think about this in two different ways. There are a number of specific requirements that you have to meet in order to comply with DEA regulations for EPCS, so we want to give you an end-to-end solution for meeting all of those requirements, which we'll go through in a moment. But it's also important to deliver a workflow that's fast and easy for clinicians. Dr. Snyder alluded to this, but when you tell clinicians that all of a sudden you have to do 2 factors of authentication for a particular workflow, it introduces the risk of creating barriers and may hurt adoption. So really, we've designed our product to make sure that workflow is fast and seamless for providers through things like the push token that Dr. Snyder and his colleagues are using, but some other forms of authentication as well, which we'll go through. So as I mentioned, Confirm ID for EPCS is really designed to be a complete solution, helping you meet all of the requirements for EPCS. So for example, there's an identity proofing step, or the credentialing that Dr. Snyder referred to. The DEA allows 2 types, individual or institutional. Individual, where each of your individual providers will go through what's called a credential service provider, and that's really a third party where they'll go off to a website, enter a series of information, personal and financial information, to prove they are who they say they are, validate their identity. We offer that service to a partner, Symantec. But the other method is institutional, and that's what they're using at Peninsula Regional, and that's where, as a DEA-registered entity, the hospital itself can conduct the identity proofing through the credentialing office. And this is most often the case, what we see. If the hospital or other organization is able to do institutional, that's generally the path that they choose because they have a little bit more control over it, and quite frankly, it's a lot easier for the physicians. However, we know that many organizations cannot do that, so therefore Imprivata will offer both individual and institutional identity proofing. We also offer what's called supervised enrollment for the actual issuance of 2-factor authentication credentials. And this is where, when enrolling the token or fingerprint biometric, the physician will actually do that in a supervised way, where an assigned witness will authenticate to prove that, yes, this physician who has gone through the identity proofing enrolled a 2-factor authentication credential in a DEA-compliant way. And that really will bind the identity of that physician to the credential they'll use for EPCS to create a nice secure audit chain that the DEA is looking for. It also makes it a lot easier for that physician to get the enrollment right the first time, which is especially important in the case of fingerprint biometrics. They'll have a good experience right out of the gate because they'll enable them to enroll it very easily and very quickly. Confirm ID will also integrate with all the leading EMRs and e-prescribing applications. In Dr. Snyder's case, they're using Epic, but certainly if you're using a different EMR or e-prescribing application, will integrate right within the workflow. We also offer a breadth of two-factor authentication options aside from just that push token notification. And again, the idea here is to give you the flexibility to use the authentication options that will best meet your provider's needs in any prescribing scenario. And we also want to give you the flexibility to have backup in case the provider does not have their phone, can't use that push token, but still needs to prescribe narcotics electronically. And then the product offers a host of different auditing and reporting capabilities, from the identity proofing to the supervised enrollment of credentials to the authentication itself, all of which are necessary to meet DEA requirements. So again, complete end-to-end solution for helping you meet all the DEA requirements, but also designed from the clinical perspective. We really want to make that workflow as fast and easy as possible. So as I mentioned, we do this in a couple of different ways. First, integrating directly into that e-prescribing workflow. We don't require your providers to go off to a separate website or another pop-up screen in order to complete this process. It's built right into the workflow. As I mentioned, we also offer the broadest range of two-factor authentication options. So as Dr. Snyder mentioned, they're using the push token notification at Peninsula Regional Medical Center, but we also offer a couple of different options. One he sort of alluded to is what we call hands-free authentication. And that's where a token running on that same app that enables the push token is actually read wirelessly using Bluetooth technology, so the physician can authenticate without actually having to interact with their phone at all. They don't have to take it out of their pocket, they don't have to press anything, and they certainly don't have to unlock it and manually enter a 6-digit token code. It all happens wirelessly. So we also offer fingerprint biometrics, and you can imagine the combination of fingerprint biometrics plus the hands-free authentication or even the push token really provides two-factor authentication that's incredibly fast and exceptionally efficient and convenient to really make this process as smooth and seamless as possible. Certainly we support things like password and then conventional tokens, whether it be a hardware token using a key fob or the soft token entered manually from the app. So again, all different options and different combinations that are going to best meet your provider's needs. And another way we ensure efficiency is that by only presenting the physician with the authentication methods that are available and allowed at that time. So if you have a provider that is not enrolled with fingerprint biometrics, but the rest of your staff is, the product will know that. And when they authenticate for EPCS, it will not ask them for fingerprint. It will default to the next set of available options. Conversely, if they are enrolled in fingerprint biometrics, but are prescribing from a machine that doesn't have a reader attached to it, or maybe they're at home where they don't have a FIPS-compliant reader, again, the product will recognize that and it will default to the next set of authentication options, presumably in that case a password plus the push token notification. And then, as Dr. Snyder talked about, they use our single sign-on product as well, and Confirm ID is really built to be a platform, an authentication platform, to help you meet all of your different authentication requirements across the organization. So we've been focused primarily on EPCS, and certainly Confirm ID will do that for you and meet all of those needs. But from that same platform and using the same authentication modalities, we can allow authentication for things like remote network access through your VPN, access to cloud applications, maybe through Microsoft ADFS. We have other support for other clinical workflows within the EMR, aside from EPCS, that don't come with all of the stringent compliance requirements, but you may want to enable authentication, things like prescribing non-narcotics or witnessing type workflows for certain medications. We're also enabling authentication for certain medical devices, so you know exactly who is accessing what medical device, what information, and what they're doing with that information. And the benefits of doing this really from a single solution is the idea that you can centralize all of your authentication policies from that single platform. And because you can use the same authentication methods, you're going to make that security invisible and the authentication very consistent for all of your users. And you'll have a nice, concise way of auditing and reporting on all of the different authentications for all of these different workflows. And that's really important, especially when you bring in sort of the breadth of the Imprivata authentication platform, which then extends those same principles out to workflows such as single sign-on, virtual desktop access, and a number of others. So you can now have standardization on a single solution, which will really reduce your total cost of ownership and ease of management over time. And you don't have to worry about dealing with different vendors and different solutions to enable these different workflows. From a single centralized platform, you can enable authentication for all of these different workflows across your enterprise. And again, extending out to different workflows such as SSO and VDA, you can make that security truly invisible to your providers, which is really going to allow you to enforce security, maintain compliance, have better control and visibility over patient information without getting in the way of patient care. So with that, I'll turn it back over to you, Lizzie, for questions.
All right, great. Thank you both. As Dan said, we will now move on to the Q&A portion of the webcast. Audience members can submit questions using the question tool to the left of the screen. We will take a brief pause now to give audience members a chance to pose questions. All right. Our first question is for Dr. Snyder. How are you handling mid-level practitioners?
Yeah, so our mid-levels utilize Imprivata. The state of Maryland allows PAs and MPs to prescribe controlled substances, so they are enrolled just as providers, so they have the same credentialing process with their DEA and CDS, so they go through the exact same process.
All right, great. Our next question is for Dan. If we do institutional ID proofing, does that mean doctors will use our organization's DEA number when prescribing?
Yeah, it's a good question and a very common one, and actually it sort of relates to the previous question in some way about mid-levels and PAs and interns and things like that. So the answer is no. The answer is that just like today on paper, the individual physician's DEA number will be on the prescription if you're doing it electronically, regardless of how you do the identity proofing. Institutional identity proofing essentially gives you as the organization, again, the authority as a DEA registrant itself to conduct the identity proofing. But the number, the DEA number, will not appear, the institutional number will not appear on the prescription. However, the exception might be in the case of some of those mid-levels where the organizational DEA number followed by that unique suffix is what appears on the prescription. But again, that's the same as it is today on paper. That'll just apply in electronic world. So it's a very common question as you're thinking about EPCS and how you will do the identity proofing. You have to separate out the use of the organization as a DEA registrant to do the identity proofing from the DEA number that will actually appear on the prescription.
All right, great. Our next question is for Dr. Snyder again. How did you work with retail pharmacies to make sure that they accepted electronic prescriptions?
Yeah, we get this asked a lot when we enroll providers. So, because again, they're concerned. Well, fortunately, within Epic, there is workflow that identifies if the pharmacy actually accepts narcotics, and you'll get they'll default to print if they do not. So that's fortunate. So that does help things. But that being said, we went out to the pharmacies, and my pharmacy director is very involved in not only community pharmacies, but in the SNF and long-term care facilities and the acute rehab centers. We also engaged all of them. So we actually did a lot of pre-Epic go-live awareness to them. But they seemed, they're very accepting of it in most cases. They just wanted to know about the change, and in fact, they were hollering at the doctors to get on there sooner than later. So there's a big push for them, obviously, because of the security and the reduction of phone calls, and just the completeness alone of the prescriptions and the accuracy you have them makes a big difference. So it wasn't a real big deal. We just had to let them know what was going on, and that was done by my pharmacy director. We actually have an in-house pharmacy also called Home Scripts that we utilize. And that pharmacy is always one of those where, especially when you're discharging from the hospital, if the pharmacy that's in the community does not accept, you can always send them through our Home Scripts, and they can fill their discharge scripts. So we're pushing that a fair amount, so we make sure we reduce those readmissions.
All right, great. And we have another question for Dan. If I'm logged into the EMR, have I completed the first factor of authentication?
No, that's another common question that we get, and the answer is no. The DEA stipulates that at the time of prescribing, you must enter 2 factors of authentication. So, password plus the push token or password plus fingerprint, but it's got to be those 2 factors at the time of prescribing, which, again, is really why we try to offer flexibility to use different fast combinations for authentication, because we know that requirement could potentially be a burden on physicians. I'll also say that there are many authentication options out there that will only handle the second factor of authentication, and that first factor will always need to be the native EMR password typed into the EMR, and then it will call out and ask for that second factor. When you see that, that can potentially be misleading because it gives the impression that maybe a single factor at the time of prescribing is all that it takes. But really it looks like that because it's only that second factor that those other vendors might be handling. So that is a common question that we get, and just a word of caution, if you see that, you are required to do 2-factor authentication at the time of prescribing.
Okay, great. Our next question could be for either of you. What year was the main EPCS mandate?
Yeah, I could take that one. So that was actually passed in April of 2016, last year, as part of a much broader, comprehensive bill passed in Maine with different initiatives and programs designed to fight the opioid abuse epidemic. One of the key parts of that law as well was a mandatory check of the state PDMP, prescription drug monitoring program, which they have in many other states. But part of that was mandatory e-prescribing. The law itself actually requires e-prescribing of opiate medications. Now, that in effect is an EPCS mandate because opioids are controlled substances, and in order to prescribe controlled substances electronically, you must meet all of the DEA requirements that we've been talking about. So yeah, that was passed into law in April of 2016, and the deadline to comply is just a few days away, July 1st of 2017.
All right, great. Our next question is asking for some clarification. For 2-factor authentication for EPCS, do physicians have a choice of what methods they use, such as token versus biometrics versus Bluetooth method, or do they just choose which two to use?
Yeah, it's a great question, and it's really one of the key advantages of using the Confirm ID product is that we give you the flexibility to offer whatever combinations you would like to your providers. You don't have to enroll. You can enable some providers for fingerprint biometrics, but you don't have to enroll others if they don't want to use it, or in some cases, some people's fingerprints simply can't be read. We always recommend having different options enrolled, again, as backup and kind of to introduce flexibility. But really, it's up to you, your policy, and your provider. You can absolutely give flexibility, and you can use any or all combinations of things that we offer. And when they're prescribing, again, depending on what's available to them at that time and what they have enrolled, they'll only be presented with the fastest combination of authentication methods available to them at that time.
Yeah, and we, from a user side, we literally gave offers out there. But I'll be honest with you, the print Bluetooth capability is again, if you're doing high volume scripts, like I said, I think our pain guys, the oncologists are probably the ones you want to roll those devices out. The devices are a little larger and require a little bit more installation. Therefore, it's something that's going to be different. Whereas when you have the push notification, there's really very limited device additional to the tools. So if you're only doing 1 or 2 scripts a month, it makes a lot of sense to do that. But we offer all the options, and we kind of go over with whichever department they're in to make sure that they get some input into what resources they want to use. We do try to keep it consistent per provider group.
All right, great. That concludes today's healthitsecurity.com presentation. Special thanks to our speakers, our audience, and Imprivata. Thank you, everyone, and goodbye.